Action. Well, welcome to the podcast, Sandi Hazlett. I'm very excited to have you, Chief Development Officer. Did I get that right?
Correct.
Of Unity BPO. Well, welcome. Thanks for joining us.
And thank you so much for having me. I'm looking forward to this conversation all day.
So have I. I appreciate that. So tell us a little bit about yourself and a little bit about Unity, too.
Sure. So I've been in IT for the 25 plus years of my career. I started in actually the federal contracting space.
Wow.
So worked with public sector a lot and did a few different types of systems, child support systems, pension systems. I did marketing for those. And then eventually ended up in the healthcare IT space. So I've have the I in IT is what I say about myself. I'm the information part. I am not the technology part, so I can't fix anybody's computer, but I can talk about them and their benefits and the things that we like to do with systems from a human perspective.
So talk a little bit more about the I in the IT.
So I have a master's in English. That was my specialty, so the writing part of all of that. So how do I communicate to end users or to customers what is the benefits of that particular system? What are they going to solve? How is that going to make lives better? What is it going to do from a cost perspective? So my part of I is the information part. I started my career doing information databases. This is back in the time when the way you did an information database was you read articles, abstracted it, indexed it, and sent it off to the Philippines for being coded in, and then they would come back on those big tape drives, and you had to proofread everything, including the spaces, literally by character, in order for those databases to be searchable.
So, what were these early databases?
Employee benefits, talking about things like that, or even databases around magazine articles and things that people might be researching on science or technology or any of those types of.
So you've seen quite a shift.
Oh man, It's been amazing.
So what took you from sort of these other industries like marketing to come into healthcare?
I think that one of the things that really, as my company now started off doing public sector work, but we had some healthcare clients. And we decided to spin off the healthcare because I think it needed a big focus on the types of problems that I think doctors and nurses faced specifically. So we ended up spinning off Unity from that company. We subsequently sold the other company. And now that I think that's really helped us really be able to focus much more on what are those particular issues that healthcare is really being driven by.
So I'll ask you the rhetorical question, but I'll look for a response. So what makes healthcare so much different than the public sector or any of these other sectors that you were working in, or of the spin-off that you spun off? Why was healthcare so special?
I think the pat answer is it truly is life and death. And for us, I think those particular end users had a sense of urgency that sometimes the public sector doesn't really have. In some ways, they're similar in that engineers, which are often our end users in the public sector, I think can be is demanding from that perspective of they want really good, accurate service, much like physicians and nurses. But from a sense of urgency, I think healthcare was really, really different than the public sector.
What does the Chief Development Officer position entail?
So the way we define that is I need to develop and grow my staff across the company. And so I head up functions like training and HR. From that perspective, but we also need to grow and develop our client base. So I head up functions like marketing and sales and contracting.
That's a pretty wide portfolio.
Yeah, both of them take a lot of writing.
So since talent acquisition probably falls or rolls up to you, seeing what we're seeing in the rest of healthcare from a talent resource containment or constrained resource of talent, how is that impacting your business and what Unity does?
I think just like everyone else in this market, I mean, whether it's healthcare, whether it's IT, that shortage of talent is something that we really have to work at. So part of our approach to that has been, seek out really talented younger people who have those skill sets and then train them up. So we're doing an awful lot of that training inside our company and getting them started on those career paths, or people who have maybe some experience that is relevant to what we're doing, and then add on top of that, how do they do that from a technical perspective? So you can take MAs or PAs or maybe nurses who are kind of done being in the field and say, let's take that medical knowledge, bring that into the technology space and help them just add on those technical skills to do a little bit more technical troubleshooting when we're addressing EHRs.
So I'm interested in the training aspect, because having been an executive in several health systems, I sort of lamented what I viewed as a lack of training for some very critical areas. And it wasn't, I don't think it was intentional. I don't think anybody was being malicious. I just think the time pressures were so huge and the need was so great that you found the next warm body and you tried to put them in the chair and you gave them just enough training to be successful. But you talked more about development and growth. I mean, and so to me, it sounds like you're really adopting the concept that if you get an employee, it's far easier to train and encourage the growth of that particular employee than to have a revolving door of employees. So what's sort of special in terms of your talent acquisition and the training that you do that might be different than what, say, a health system is able to do?
So I think that because we are focused on being a contact center, that we can apply training and tools that are really specific to being a contact center. I think health systems don't always have that luxury. I mean, there are so many other places that they have to spend their dollars, and that's not their mission, is to be a contact center, right? Their mission is to really cure humans. But my mission is to really be a contact center, so I can really focus on what are the processes, what are the frameworks, what are the tools, what are the educational needs of that group. And so I go from there.
So the framework that you have for developing expertise in contact center is fixing a problem that exists within healthcare today or hospital systems today. What I'm hearing from you is that there are many other competencies that hospitals need to have that are more important than just picking up the telephone. And you can say, well, we will become, and I'll oversimplify this, experts at picking up the telephone and helping patients. So why do you think that's not something that health systems should be doing? Why? I mean, the whole notion of the general hospital is it does a little bit of everything. It does a little bit of neurosurgery, does a little bit of oncology. It has hoteling functions. It has to have, real estate functions. I mean, it's a complicated beast. So why not just let them do it?
There are pieces, I think, that the hospital systems will end up doing. I think we're looking at, automation and how do we take off of their plates some of the things that they don't need to do and try and let those healthcare workers, whether it's the nurses or the back office staff or the physicians, and I'm going to use the terminology, practice at the top of their license, meaning really apply the skills that they need to do at that area and move off of their plates the things that they don't. So I think there's always going to be some sort of combination then.
So you mentioned automation.
Of course.
What's your view of automation? Where does it fit within sort of your book of business?
I think that it fits within, well, I'll just say this. Unity, I think, really lives at kind of that human and technology intersection. So helping clinicians and patients, use their technology better is our mission. How do we be a lifeline to them in those moments when they really are struggling with it? I think that has been a human touch at the moment, much like healthcare itself. It's been a human touch. But I think automation is starting to come in because it's getting better, right? And you can actually have some of those interactions be more automated. And so I think as part of our business, we are just going to see both that combination of here's the things that can be automated, here are the things that I still need to escalate to a person. And I think that's going to be really true whether as a contact center or whether as a physician, right? In that patient experience, I'm going to make some choices as a physician about what are the things that I can offload, automate, turn to others versus what I need to do myself.
What are the types of interactions that your company's thinking about in terms of ripe for automation?
Well, I think right now we're obviously talking with Syllable and putting together our joint partnership, and certainly that mainline scheduling and appointments and prescription refills, those types of things that we're working with Syllable on are going to be ripe for us integrating into our business.
I guess the question that a lot of people would have is, as a contact center company, we said it earlier, you answer the telephone with a human being. So how does automation not cannibalize your business, and how do you successfully integrate automation moving forward? Because it's seemingly, I guess the underlying question is, a lot of automation can be FTE replacement automation. A lot of automation can be assisting people working to the top of their license or their training. So how does that fit in with Unity's strategy?
And our strategy is that there are things that we are still going to have to do from that human perspective, and there are things that are going to be escalated. And we are still, I think, in this time of flux at the moment where the patient population or the clinician population is going to still need some human intervention. I still am going to have to remote in to some of those nurses' tablets and laptops. I still am going to have to do some of that. Even with the automation, there's still going to be patients that are going to say, this is too hard for me, and I'm still going to call. Right. So I think it'll move. I think it will evolve. But I think there's still going to be some of that right now.
Why did you and your team come to VIVE, to a conference like this? What were you looking to achieve or looking to connect, or was it just COVID's on the way out for right now and we need a chance to get out?
Truthfully, some of that's just there. A couple of years hiatus, and
right.
So it's nice to be back in person. But certainly, I think VIVE and its mission of really talking about technology and where it's going and how it can really improve both the patient experience and the provider experience is where we want to be.
So we've all been patients, or we all will be patients. Can you think of an exceptional patient experience that you have had that you might be willing to share?
I haven't had too many
or
of those.
Or a loved one.
Yeah. So I lost my father this last year.
I'm sorry.
But he had a really great home health experience. He really had an amazing set of nurses who came, and I think one of my more prouder moments is that Unity has always been in the home health care space. Well, I shouldn't say always. It has always, but like for a really long time. And so being able to help those nurses from that perspective of a business and saying, okay, this is what we do, but then also on the receiving end of that, to watch those nurses, how they work, the tasks that they had to do, was really gratifying.
And what was it that made it, I mean, aside from supporting the professional work, what were the things that made it a really good experience for your dad or for your family?
I think it was a really good experience for my father because, unlike a lot of people, he actually had the chance to die at home. I think that for people of his generation, the idea of going to a facility of any sort to end their lives was not something he wanted. So the home health and hospice nurses really allowed us to give him that passage the way he wanted.
Right. Oh, that's wonderful. Yeah, it's interesting. When I practiced medicine, there was this moment where you had to have the discussion with the family of we need to transition the way we're thinking about the outcome of your loved one. It's clear that the end is going to be at some point in time, and I always thought that the best place to die would be at home, and that's what I would want, and that's what I've told my kids, and that's what I told my wife, and that's what's in the living will, all that kind of stuff, because I just felt like who would want to die in a hospital or a facility for that matter. But what I learned over time was that there are just some families and some individuals for which that's really tough because it's a lot of work. And if you're not bought into how much work it's going to be, and you're not bought into the emotional journey, it can be really painful for some patients. Even though I know that if it had occurred in the hospital, it would have been 10 times as painful because hospitals aren't set up for patients to pass on. Hospitals are set up for patients to survive and to move forward. Now, yes, some hospitals do end-of-life care very, very well, and I don't mean to denigrate the work that they do, but it is what I originally had thought was sort of very black and white in my own mind became very gray as I talked to more and more patients and helped them make that transition.
Well, and certainly you can think about it from that kind of objective viewpoint. Like I said, we talk with hospice and home health nurses on a regular basis, so you have that objective viewpoint. But when you experience it personally and that amount of work,
right,
you're correct. It was. I really wasn't prepared as I thought I was.
Right. Well, I want to transition a little bit to some other work that you do. So I found that you were the board chair for an organization called Heading Home, and I was really impressed with that whole concept. So talk a little bit about the organization, why you're involved, and what they're trying to do.
Sure. So Unity has a social mission side of the business, right? We are part of our philosophy as a company is that giving back to our community is just as important as the work that we do in earning a living. So one of the things that we had gotten involved with is the homeless in our community. So that is what Heading Home does. They serve the homeless population. It is directed at men. So we have some other nonprofit organizations that are directed at women or families. And so I ended up getting involved with that by starting as just volunteering and helping them with their technology. And of course, then my staff was really interested in doing some of that because they like technology. So that's kind of how it got started. And then it just continued on where we would volunteer and help with services or events that Heading Home was putting on. But that was how it started.
So I have to believe that a lot of the problems that they solve or try to solve have to do with the social determinants of health. Clearly they're homeless, so trying to find a home, trying to find a safe transition to health care, to a roof over their head, to food and things like that. Why are those things important? I mean, it's not typically what medicine sees as its role in terms of helping people. We're really good at making a diagnosis and prescribing a treatment plan, and where you live and what you eat and the air you breathe doesn't tend to fall into that. At least I didn't get any courses on that in medical school. So just as a person outside of being a Unity employee, just somebody who's been interested in this population, what have you learned about those things as time has gone by?
Well, I'll tell you a story. So one of the things that I certainly learned about the homeless is, there's a range of why people are homeless, right? The things that end up creating those situations are really varied. And there was a man who told us his story, which was that he was a TV cameraman, and he worked locally, and he had a heart attack and had no health care at the time.
Wow.
And that particular experience of having a heart attack and having to go to the hospital ended up bankrupting him. So he was homeless, and he came to our organization, which has a shelter, and it has a respite care program. So we work closely, the organization works closely with our local university hospital, and they set up this respite care program, and the residents come and help people like, his name was Jack, who had the heart attack, transition, because if you put them right back out on the street, they are not going to recover.
Right.
That's just illogical. And so he came to the shelter, and he was in the respite care program. We helped him get back on his feet from a recovery perspective, but we also wrapped case management around that. So Heading Home uses a housing first model to get people into housing first, and then you address their issues, whether that's substance abuse or they might need services from the VA
Right.
or other places, right? So you have the case management that goes around it. So we helped him with some other social services. He ended up then being employed, even though he was living out of his RV. And once he kind of got back into that cycle of employment, then he could get into onto his own 2 feet.
Wow.
And he talked a lot about that and was a real advocate for that type of a model where you could get into housing, get some temporary help, get all the organizations that you need in order
Right.
to readjust your life. But that's kind of what he talked a lot about. And it was an area that I had not thought a lot about personally, about why people end up homeless, and his whole situation where you really realize that healthcare can both help but also ends up hurting people was eye-opening.
Right. Yeah, it's a big gap. You come into a hospital and you're broken. You've been in trauma, or you've had some medical issue like you just described. We patch you up. We don't make you 100%, and we don't figure out what happens outside our door. But we'll get you to the front door, and then today, with case management and social work, we do a better job than we did 50 years ago, but there's still a lot of people that are not having their needs met at the time of discharge. And I always felt that being on the hospital side, we had this, probably the worst metric that we ever followed was length of stay. And everybody always wanted to get the length of stay as low as possible. And it wasn't until we started to have conversations around value-based healthcare and ACOs that I started to ask the question is, what's an extra day worth? If we're going to be on tap for a readmission, if we're going to be responsible for the cost of the skilled nursing facility, if we're going to be responsible for, an ER ambulance ride back to the ER because a drain, fell out or somebody didn't get their medicine on the right time, maybe if we keep them a day, 24 more hours to make sure that the daughter who's on the West Coast gets home and can take dad home, to make sure that there's somebody there to meet home health who can understand, because the patient's not going to understand what the home health aide is going to say or the home health nurse is going to say. And, I think that what your story really highlights is that there are all of these parts of the journey that we haven't focused on because we've had blinders on to one particular metric or another particular metric. And it's only until we take a more holistic view of the care journey, whether that happens in the hospital, whether some of it happens before the hospital, through the hospital, or all the way through a post-acute care transition back to living at home, I think is the real metric we really need to be following.
And that population, the homeless population, it really has significant challenges, and there's just so many more, the volume
Right.
is just so much higher than I think it
Agreed.
used to be. And maybe it isn't, and maybe that's just my perception because maybe it's more visible. But certainly the challenges for those folks in addressing all those needs, right? So they can't get the correct nutrition,
Right.
How are they going to heal? They've had other issues that are compounding whatever is that's been the immediate trauma that they're trying to address.
Yeah.
Certainly the respite care program, I think, as part of that organization was just a little bit more of help to kind of transition from what you said, they're being released, to at least can they somewhat function on their own?
Yeah, I saw evidence of the help of a respite program when I was in Connecticut. We had a sister hospital in Springfield, Massachusetts, which is only about 20 miles away, and they had started a respite program in the community. Again, similarly for homeless or for people that lived alone and needed a little bit of support, but they either didn't have a payment source for subacute care or they didn't qualify for it. And hearing some of the stories was absolutely amazing. People saying, quite honestly, if I didn't have this, I'd be dead. If I didn't have this, I'd be on the street. If I didn't have this, I'd be back in the hospital. And it's amazing. And it doesn't cost a lot of money to do it. It doesn't require a lot of skill. People can be taught to do simple things to take care of themselves, and you can develop a community of helpers around them. And fortunately, the regulators haven't gotten involved to say, you need to meet certain requirements. So
yeah, and I think a lot of us take for granted our own support networks
Right,
that
absolutely.
folks like that don't have.
Right.
And as part of the board, I was really thankful that the funding that Heading Home got was some was federal grants, but a lot of it came from private donations or the city of Albuquerque,
Wow.
which chose to fund that program. And then, of course, having a teaching hospital there, right, you did have access to those students who were really interested
Yep.
in helping the homeless and honing their own skills as they did so.
Yeah. My daughter's a first-year medical student at University of Connecticut, and they have the students run a clinic in one of the homeless shelters in Hartford. And she went a couple of weeks ago for her first visit, rotation, whatever they call it. And she said it was amazing. It was completely eye-opening, and it opened her mind and her eyes to something that she knew existed, but she just didn't get a chance to see it up front. And when you do, it changes you completely.
It really does.
Yeah.
Well,
Sandi.
good for her for doing that.
Yes, exactly.
So thank her.
Yes, I will. Every day. Thank you for being on the podcast. This was
Certainly.
an excellent conversation. I really appreciate it. And thanks for being a friend of Syllable. And hopefully we can have you back.
I would love to.
Good. Thanks so much.
Thanks, Adam.
Appreciate it. Good job. That wasn't bad, right?
No, that was fun.